Emergency dentists treat pain, infection, and trauma. They pull teeth only when necessary. Each year in the U.S., millions visit EDs for dental pain, but extractions rarely happen. Emergency dentists extract only when non-restorable, spreading infection, hopeless prognosis, or patient chooses. Otherwise, preserve. Emergency dentists offer care in clinics or on call, imaging, anesthesia, drainage, endo, extractions, sedation, selecting definitive or interim. Common emergencies: pulpitis, abscess, pericoronitis, trauma, cracks. Preserve first. Extract when hopeless. Next, care setting. EDs rarely extract. Emergency or after-hours dentists do simple ones. Oral surgeons handle complex cases. Next, decision drivers. 6 factors guide emergency extraction: restorability, infection, severity and spread, function, medical safety, patient priorities, anesthesia, and access. First, triage red flags. Assess and test. Determine restorability, infection, outline options, risks, consent. Act or defer with safety net. Stop routine extraction if red flags present. Prioritize airway, urgent hospital care, and source control via oral surgery. Rapid triage. Stabilize pain safely. Respect ASA risk. Then diagnostic tests guide definitive treatment decision. Cold EPT, percussion, bite release, probing, and imaging guide preservation versus extraction, then restorability and prognosis. Preserve when ferrule attainable, caries accessible, crown to root acceptable, strong periodontal support, no resorption, strategic value. Extraction indications next. Emergency extraction is indicated for non-restorable, infected, fractured, or hopeless teeth. Conservative alternatives come next. In emergencies, preserve teeth with endodontic relief, drainage, and temporizing stabilization. Next, quick decision matrix. Match diagnosis to immediate action. Pulp therapy, RCT with drainage, extract non-restorable, mimics up next. Differentiate pulp, periodontal, and sinus causes to avoid unnecessary extractions. Spontaneous, chewing localized, multiple tender teeth. Inflamed vital pulp causes lingering thermal pain. Urgent pulpotomy or pulpectomy relieves, preserving the tooth. Necrotic pulp, acute apical abscess, drain or open canals. Extract when non-restorable. Antibiotics if systemic. Periodontal abscess shows deep pockets, pus, and angular bone loss. Hopeless periodontitis often requires extraction. Vertical root fractures permit bacterial ingress. Prognosis is poor and repair unreliable, making extraction standard. Most cracked cusps and crown cracks are saved with restorations. Vertical root fractures aren't salvageable. Pericoronitis inflames tissue over erupting wisdom teeth. Trismus or spreading infection may require urgent removal. Trauma care favors preservation. Replant permanent teeth, splint luxations. Extract only when unsalvageable. Primary teeth differ. Details ahead. Baby teeth fail quickly. Abscesses need extraction. Avulsions aren't replanted. Maintain space. Next, bleeding risks. Most emergency extractions are safe with anticoagulants. Verify INR. Time DOX. Continue antiplatelets. Prioritize local hemostasis. Consult physician. Uncontrolled disease or deep space infection warrants hospital OMFS. Use a protected airway and IV antibiotic. During pregnancy, urgent extractions are appropriate when necessary. Use shielding, safe anesthetics, and trimester-aware planning. Reserve antibiotics for systemic involvement or cellulitis. Irreversible pulpitis needs definitive dental treatment. Use amoxicillin or penicillin V. Hot mandibular molars often resist anesthesia. IANB 55%, add articaine 70%, intraosseous 85%, consider sedation. Sedation options differ by case. They complement, not replace, local anesthesia. Next, simple extraction overview. Simple extractions: X-ray, anesthetize, luxate, forceps remove, compress, gauze. Instructions: no flap, surgery next up. These take longer with more swelling and trismus. Sedation often considered. Next, dry socket discussion. Dry socket, extractions 1 to 5, third molars 5 to 30, higher with smoking, contraceptives. Most complications are uncommon. Nerve injury usually temporary. Persistent deficits are rare. Next, healing timeline. Socket healing progresses: clot, epithelium, bone, remodeling. Next, we compare pain relief trajectories across treatment. Pulpotomy relieves within hours. Extraction stops pain. Drainage reduces pressure. Antibiotics alone unreliable. Next, costs. Typical extraction costs vary by country, clinic, and coverage. Sedation and timing add. Next, access. Emergency departments manage pain, not extractions. Definitive care at urgent dental or oral surgery clinic. Choose imaging to map roots and vital structures. Next, immediate versus delayed for pericoronitis. Trismus. Extract when access and anesthesia succeed. Delay for trismus. Assess risks, expertise, then patient value. Balance long-term success, function, and cost with immediate control, replacement needs, prognosis, and strategic value. Emergency dentists perform same-day extractions only when safest and necessary, prioritizing tooth preservation. Top extraction triggers: non-restorable destruction, vertical fracture, hopeless periodontitis, acute infection. Deferrals next. Delay extraction when teeth are salvageable, traumatized, access limited by infection, or medically unstable. Quick comparison: save, extract, or temporize. Next, we cover core patient safety principles. Extraction safe: reserve antibiotics, anesthesia or sedation aids, complications low. Next, follow-up milestone. Peak soreness, 24 to 48 hours. Sutures, 5 to 10 days. Pulpotomy eases pain. Finish root canal. Let's bust emergency tooth-pulling myths today. Next, quick guidance on costs and coverage. When budgets are tight, extraction often wins. Coverage and insurance shape timing. Options: emergency dentists stop pain fast. Save teeth when possible. Extract only when necessary.